Thank you for joining us today as we discuss naloxone as a critical tool to fight the opioid crisis. This is a continuing medical education for multiple providers. My name is Laura Palumbi, and I'm a pharmacist at the University of Minnesota College of Pharmacy. I work with rural health departments and coalitions to find solutions to the opioid crisis, and I'm also a member of the Carleton County Drug Court team, where I've gained an appreciation for the recovery process.
And I'm Heather Blue. I'm an assistant professor at the College of Pharmacy here in Duluth, with a clinical practice site at St. Luke's Hospital in Duluth in the emergency department. So I have seen firsthand the effects that opioids can have on our population.
We'd also like to acknowledge our collaborators, Dr. Elizabeth Bilden, who works for Essentia Health and St. Louis County Public Health, who had a key role in organizing this CME, as well as Lauren Hansen, PharmD from Essentia Health. Before we begin, we do want to let you know that we don't have any conflicts of interest to disclose. Funding for the CME is provided by the University of Minnesota and the Minnesota Statewide Targeted Response to the Opioid Crisis Grant. Off-label uses of naloxone will not be discussed during this presentation. We also really want to thank our partners, because this continuing medical education and all the work that's been done for the STR grant wouldn't be possible without them. St. Louis County Public Health and Human Services, Carleton County Public Health and Human Services, the Rural AIDS Action Network, St. Luke's, Essentia Health, the Minnesota Department of Health, the Minnesota Pharmacists Association, the Minnesota Board of Pharmacy, Minnesota Poison Control System, and the University of Minnesota College of Pharmacy. This CME will bring together some themes that we learned about in a pharmacist survey that we administered last fall, so in 2017. We learned a lot about the current barriers to naloxone distribution, as well as syringe access and authorized take-back. So we're going to let you know some of our findings and discuss those throughout this presentation. The objectives of today's presentation are to state some factors that may increase a person's risk of opioid overdose. We're going to identify signs and symptoms of opioid toxicity so that you're able to counsel patients and recognize those signs. We're also going to go through the pros and cons of the different naloxone formulations that are available. We're going to review resources that your patients might use to access naloxone, same resources that you can give patients as they're trying to learn more about this drug. Also describe legal considerations for prescribing and dispensing of naloxone in the state of Minnesota, and to discuss available naloxone and opioid resources for healthcare providers and for patients. Before we begin, we just want to look at some trends in overdose deaths involving opioids in the United States. These are probably familiar to you, but it's good just to set this presentation in context. And we know that opioids are causing a lot of overdose deaths in our state. And naloxone, of course, is a drug that reverses opioid overdose. So it's a critical public health tool as we strive to turn the tide on the opioid crisis. And you can see how the different kinds of opioids line up next to each other. So synthetic opioids such as fentanyl and tramadol, which we've seen sharp increases in, as well as commonly prescribed opioids that you're actually dispensing from your pharmacy most likely, or from your emergency room. And then of course heroin is also in the class of opioids, so we're seeing a rise in heroin overdose as well. We also wanted to briefly talk about how the U.S. opioid crisis has impacted us in the state of Minnesota, and some contributing factors too. So we do know that $20 billion is spent annually on emergency department and inpatient care for patients with opioid poisoning. This is a lot of money, but beyond the money, these are people's loved ones. These are our family members. These are our community members. So as we talk about the numbers, I think it's important to also realize that these are real people, and a lot of people have been impacted by the opioid crisis, and it's a very personal issue. So keep that in mind as we're looking at numbers as well. Since 1999, more than 165,000 people have died as a result of overdose due to prescription opioids. And of course, we know that addiction fails to be acknowledged and treated as a chronic medical disease, and the stigma of addiction continues, serving as a barrier for turning the tide on the opioid crisis.
So before we can talk about how we reverse opioid overdose, let's talk a little bit and have a little refresher on the opioid receptors and their action. So we know that opioids can affect multiple receptors. These include the mu, kappa, delta, and ORL1. We're most specific, and most often we're talking about the mu receptor. And the reason the mu receptor is so important is because That's the receptor when it's activated that can cause the overdose pieces and especially the respiratory depression. So as we go through, be thinking about those mu receptors and how the opioids sit on those receptors and then cause, again, that respiratory depression, which can lead to death. Other signs of opioid overdose include a patient's breathing will be slow or maybe absent. Because they're not getting enough oxygen, their lips and nails may become blue. They may sound like they're choking or have gurgling or snoring sounds. Excuse me. Also, again, because they're not oxygenating well, they might be really hard to awaken, and their skin will feel cold and clammy. We used to always say that a good sign of opioid overdose is that the patient's pupils become really tiny, or miosis. Although that is still true with opioids, we're also seeing a lot of synthetic opioid use. And a different caveat with those is that the synthetic opioids, not all of them will cause that miosis. So if you have a patient who's having a lot of these other signs, maybe they're making those funny breathing sounds, or they're not breathing at all, and you're wondering, could this be opioids? And you look at their eyes, and their pupils don't seem to be any different size. It still could be opioids, and it's still important that we would use the rescue drug naloxone, which we'll talk more about later. We also need to set some groundwork of medication terms that we'll talk about. So you'll see a lot of these in practice. You might hear morphine milligram equivalents, or MMEs, morphine equivalent dose, MED, morphine dose equivalents, MDE. They all mean the same thing. So it's just a way to look at opioids and try to set a guideline where they'll all be equivalent. So if we look at hydromorphone or fentanyl, we'll put it in terms of morphine, and we can compare them with each other. If you're someone who uses this in practice and really needs to be able to see what an equivalent dose of opioids are, the CDC does have a downloadable app that has a calculator with the MME, so you're able to do that. Also, if you look on the Minnesota Prescription Monitoring Program, they calculate MME, so it's on that column all the way to the right of the MME report, or of the prescription monitoring report. There's the MME column. So it's a way for us to look at how much opioid the patient is currently using, and then as we talk about who's at risk of having opioid overdose, this number will be important. Let's look a little bit at the CDC guideline for prescribing opioids in chronic pain. So these came out March of 2016. I want to highlight again that it's for chronic pain, and so the guideline was really to when to initiate or continue opioids for chronic pain. So we're not talking about acute pain or even cancer pain. We're really looking at chronic pain. So the guidelines talk about which opioids to use, what doses to use, how long to use them, when should you have a patient follow up, and when should you consider discontinuing the opioid. Also in these guidelines, and the part we'll focus on, are really an assessment of risk and addressing the harms of opioid use. Let's look a little bit more at these guidelines. So within these guidelines, I think some things that we want to highlight are really the preference for non-pharmacologic or non-opioid therapies. As you know in practice, there are lots of things that will help with our pain. So it's good to try other options, things like acetaminophen, NSAIDs if they're appropriate for the patient. Sometimes even as simple as heat, ice, exercise, physical therapy, trying to use those things as our primary therapy before we consider opioid. We also know that immediate release opioids are recommended over long-acting or extended release products. So this has, as much as we want that medication to be extended over a longer period of time and we think that would have better coverage for pain, it actually puts us at a higher risk of abuse. And in some regards, it's just a greater risk of overdose. So if you have that long-acting medication on board and then we're taking additional immediate release, you can get into some trouble as those kind of build up. We also want to use the lowest effective dose possible and for the shortest amount of time possible. We really have insufficient evidence that we should be recommending immediate release products when we're already using an extended release. So again, that's working with providers really closely to try to determine if you are going to use a long-acting product, to try to find a good dose that uses, so you don't need to be using immediate release on top of your long-acting. We also know that there are higher risks of having overdoses with our opioids if we're using more than 50 morphine milligram equivalents per day. And we'll get into kind of showing you what that number looks like when we start talking about medications. And these guidelines recommend that we really should try to avoid anything over 90 morphine milligram equivalents per day. At that point, the benefits of your opioid therapy are not, at least what the data shows, are not more therapeutic, and that you actually are putting yourself at much more risk of overdose. Some of the other things that we saw with these guidelines is that we should be using our prescription drug monitoring program. So hopefully, if you're a provider, you're using this before you prescribe medications. If you're a pharmacist, you're also looking at this as you're looking to dispense an opioid medication. Looking for flags if our patients are using multiple providers, multiple pharmacies, trying to get a better look at the overall patient in the sense of maybe they just need someone to really look at their therapy in a whole if they're going to multiple places. They also recommend using urine drug screens for patient treatment plans. So again, if you're a prescriber, have a pain clinic and really want to look at your prescribing, that you could consider urine drug screens. And then the point we really want to highlight and the focus of this presentation is that the CDC does recommend to consider offering naloxone when a patient is at increased risk of opioid-related harm. So naturally, your next question should be, who is at opioid-related harm? So this is from, again, the CDC, those same guidelines, and they establish who is at risk or increased risk of overdose. And those people are patients that are using higher opioid doses, so again, greater than 50 morphine milligram equivalents per day, and we'll look at what that looks like in medication. If they're concurrently using a benzodiazepine, so if we think about how a benzodiazepine works, it also can reduce or lower have respiratory depression. And so if we have that on board, as well as our opioid, it makes sense that we would have a greater possibility of overdose. If you have a history of substance use disorder, again, your risk of having abuse and using more of these opioids are higher potential. And if you have a history of previous opioid overdose, again, you're at risk of an additional overdose. That risk is higher. Other people who we think are at increased risk of overdose, patients with comorbid mental health conditions, so patients that already have maybe underlying depression at baseline, patients that also have comorbid renal dysfunction or hepatic disease. This may affect how the medications are cleared from their body, so even if they're given an appropriate dose, if they're unable to clear it from their body, again, that might build up. More of those mu receptors may be blocked, and we might see a greater risk of overdose. And those patients that have respiratory diagnosis at baseline, so again, COPD, sleep apnea, just because we're going to reduce their respiratory drive, again, a greater chance of overdose. Those patients who have a recent release from incarceration, prison, jail, even perhaps long stays in the hospital if they weren't receiving their appropriate, or maybe appropriate's not, but if they're kind of their baseline pain control. And the reason of this, if they had some tolerance to opioids, and then, especially in the case of incarceration, they were unable to use opioids. If they are released and then go back to using that same dose of opioids, their body has lost the tolerance. And so now all of a sudden, all those mu receptors are activated, and the patient is at great risk of having respiratory depression and overdose, possibly death. The same thing is true, a recent discharge from an opioid detox or abstinence-based program. So again, there's no use, they lose the tolerance. That first-time use has a really high rate of overdose just because their body is not used to it. So we talked a little bit about that 50 morphine milligram equivalent per day being at greater risk of overdose. And the reason the CDC sets that line is there was a study, and actually they looked at several studies But one in particular, a retrospective cohort study, looking at the association of average prescribed daily opioid doses and then their risk of overdose. And these cohorts, they looked at the overall risk and really had to set some boundaries of what numbers would go where, who was in which cohort. And so they decided to look at patients that were on 50 to 99 morphine milligram equivalents per day as one cohort, and then patients that were on greater than 100 morphine milligram equivalents per day. And you can see when they compared these two groups with the cohort that used 1 to 20 morphine milligram equivalents per day, there was much greater risk of overdose. So those that were using 50 to 99 were almost 4 times at a greater risk of overdose. And then those that are 100 were almost 9 times at greater risk of overdose. There's nothing special about that 50. It's not saying if you have a patient who's at 40 that they're not at risk. But again, as that number increases and your dose of opioids in a chronic pain patient, as they increase, your risk of overdose increases as well. And so the CDC set that endpoint, that minimum at 50 morphine milligram equivalents per day, saying that at that point you really have about 4 times a greater risk of death, and at that point you should really be considering naloxone for these patients. What that looks like when we start looking at actual medications, and it may sound, I think the first time I heard this I thought, oh, we're talking about people that are on fentanyl patches and OxyContin at high doses, but this was pretty staggering to me when you actually did the math. Again, used one of those CDC calculators. So I look at oxycodone, and again, I work in an emergency department, so I see a lot of Percocet being prescribed. And if anyone ever filled a Percocet prescription, usual standard instructions, 1 to 2 tablets every 4 to 6 hours for pain, right? Well, if a patient is using 2 tablets every 4 hours or even every 6 hours, they're automatically over that 50 morphine milligram equivalents per day. So think about how many patients that potentially is. Our patients that have their wisdom teeth removed, have a trip to the ER. That's a pretty standard prescription. A couple of tablets of Percocet, same thing can be said for a couple tablets of Norco. A few times a day, it's really easy to pass that 50 morphine milligram equivalent per day. So really when we think about that in our patients and who needs naloxone, it's a much greater group of our population than I think what I had originally thought. And then you can see in that far right column, that's the 90 morphine milligram equivalents per day. And so that's looking at what the CDC recommends for chronic pain. We should not exceed those doses in a day. And so, again, I'm drawn to the fentanyl patch. I think about that when I think about chronic pain. And we have several patch sizes that are over the 37.5. So maybe these are patients that we need to take another look at and see what are we using, what is their whole therapy for pain, or are we just relying on really high dose opioids, which have very little evidence to support their treatment. So we've talked a little bit about the medications that we use and the opioids that our patients may be taking. Let's talk a little bit more about naloxone. Naloxone is our opioid reversal or antidote. It has, like the opioids, it likes the mu receptors. And so it also, like opioids, it'll sit on those opioid receptors, but it has a higher affinity. So if we think back to what that means, it means that if an opioid is sitting on the receptor and the naloxone wants to sit on the receptor, it will pull the opioid off of the receptor and then sit on that receptor and block so the opioid can't get onto the receptor and have those effects. So if we think back to what the mu receptors do, if that naloxone is sitting on the mu receptor, the opioid can't cause respiratory depression. Same way if we have those opioids sitting on the receptors and a patient is having respiratory depression because they've a lot of their mu receptors have opioids on them. If we give the patient naloxone, it will have a higher affinity for those receptors. It'll want to sit on those receptors more than the opioid and can hold on to them. It'll pull them off, it'll sit on the receptors, and then reverse that respiratory depression. So our patients will hopefully have the ability to take a breath and to start breathing again. We have no dependence or tolerance with opioid or with naloxone. So in that sense, if we use it once, we can continue to use it. We don't need a higher dose. And the really nice thing is if we use it because we think it's an overdose of opioids, and it's not, it ends up not being opioids, it has really no effects. So it's a real safe medication to use. And as I talked about it, ripping them off the receptors, it's also good to think about, and we'll talk about it a little bit more as we go through, but it's good to think about, it rips it off the receptors, but those opioids are still floating around in the body. And so as we talk, we'll see why that's really important. But it's good to note it'll pull them off the receptors, but they are still active within the body. So if they find another mu receptor to sit on, they can still have those respiratory depression effects. When we look at how naloxone is used, we have a couple different ways we can administer naloxone. We can inject it into a muscle, give it intramuscularly. That has about the same onset as if we use it intranasal, so again, putting it in their nose. The half-life of intramuscular and intranasal are about the same. Intramuscular, it really depends on which muscle it's in, how close it is to the blood vessels, and it's taken up. So it's really much more erratic when we're thinking about intramuscular times. Naloxone is really poorly absorbed via the oral route. And if we think about how these patients are, they're not in a state to be taking and swallowing a medication anyways. So oral route is out for naloxone. The other thing that's really important as we look at naloxone in our patients, and as you're counseling your patients, is that all of these patients that receive naloxone should have medical evaluation. And that's really because of the last point on this slide. And what we talked about previously is that the naloxone will rip the opioids off the receptors, but it will fall off before the opioids are out of the system. So you've got those opioids that are still circulating within the system. The half-life of naloxone is shorter, so it quits holding onto the mu receptors, and it's eliminated, and then those opioids are still around and can come back and sit on the mu receptors and have those same respiratory depressive effects. So any patients that receive naloxone really do need medical evaluation following their administration, and just need to be watched of whether or not they can have kind of a re-overdose after that first dose of naloxone has been eliminated. What might you see after you give naloxone? So we talked about taking it off those receptors. So that's withdrawal, right? So we have acute opioid withdrawal. So we have this drug, naloxone, going in and taking off all the opioids off the receptors. Our patients are going to go through withdrawal. And what that looks like, what you'll see first is lots of different things, but a lot of patients will feel awful. So they'll have nausea, vomiting, diarrhea, abdominal pain. Again, think if they were using this for chronic pain to start with, we've now made that ineffective. And so whatever pain they had previously, back pain, it's very likely they'll have that same pain. You'll also see them, they may be sweating, have goosebumps, watery eyes, headache, runny nose. They can get really restless, and a lot of that is just because of the pain that they're in and how uncomfortable it is. Opioid withdrawal is not life-threatening in the sense that we think of some other things like our benzodiazepine. If you're going through benzodiazepine or even alcohol withdrawal, both of those can be life-threatening. Our patients can have seizures. That's not the same with opioid. It's very uncomfortable, but those patients, it's not likely to be fatal. So again, and it's really a matter of just getting them through that withdrawal time frame. When we talk about naloxone and what adverse effects that might have as we give it, again, if there's no opioids there to reverse, there's really no expected effects. So in the emergency department, we have a patient comes in really not responding. Naloxone is the first thing that we try, thinking that our opioid use is high in the population, and naloxone is really safe, and so we see if it works. If there's no effect, then it's probably not an opioid, or with some of the new synthetics, we're seeing that we have to use higher doses of naloxone. However, most of the time, if it's not an effect, it wasn't an overdose of opioids. We also see that there are some product-specific reactions. So So if we're using intranasal naloxone, we can see a lot of nasal dryness. And if we're injecting it, we can have some site discomfort. Again, both of these are really small potatoes when we're thinking about overall what could happen if we have someone, so they weren't breathing. We give them a drug, and now they're breathing again. We're not real worried that they might have some nasal dryness. But again, they were reported in the trials, and we've seen that. And the most common is that opioid withdrawal. So it's not really adverse effects of naloxone. It's just showing that the naloxone worked, and now the opioids are off, and we're seeing that with those withdrawal symptoms that we went through previously. We can also think about naloxone use in special populations. So we're often asked, well, what if I come across a pregnant patient who appears to have been overdosed? We do know that naloxone crosses the placenta and may precipitate withdrawal in the fetus. That's usually not a problem, especially if they're going to stay a fetus for a while. Again, neonatal, we know that there is a small potential for seizures in those neonates that are born with mothers of opioid dependence. Lactation, it's really unclear if naloxone is excreted into breast milk, but we know that if it does get in there, that it's really poorly orally absorbed, so there's a greater chance that the baby's not going to receive the effects of the naloxone. In geriatric patients, we know that there is a possibility that they'll have increased systemic exposure, just because usually, their liver and kidneys, cardiac function, all of that is a little less functioning. However, I think we go back to the standpoint of we only are using naloxone if a patient is not breathing. And so any of these risks that we see that may be related to the naloxone, the risks are really outweighed by all the benefits. So you have a patient who's potentially clinically dead, we're giving them naloxone. We're not, just like the nasal dryness, we're not really worried about these other possible effects because the results are really worth that. And let's talk a little bit about the products that naloxone and how they come. So we'll talk about injectable generics. So we have a couple brands that are making those generic products, Hospira and Mylan. We have an auto-injector that's a branded product called Evzio. We have an injectable generic that's actually, as we mentioned, it was injectable, but we can give it intranasally. And then we have an intranasal branded product that's branded as Narcan by Adapt Pharma. So naloxone, as we give it intramuscularly, the dose is 0.4 milligrams per mil, and so it comes in vials or ampules. A lot of these you might see if you use the Steve Rumler kits. Other kits, these are the cheapest to obtain, and so you'll see them, a lot of our public health colleagues will use these in their kits. You're able to get a lot more kits out into the public. So each kit usually has 2 to 3 vials, again, as we talk about that, and we'll give that first dose of naloxone, but it's nice to have a second dose handy and possibly even the third, so 2 or 3 vials. In order to use this, you have to draw the medication out of the vial and inject it into the muscle. As we think about injecting that into the muscle, it's really easy to think about it's a flu shot in how you administer. It's the same as a flu shot. So we can use their shoulder muscle. We can also use their thigh muscle. And again, you're going to pull up that whole mil and inject all of that into one muscle in one injection. If the patient continues to have minimal or no response, they're not starting to breathe, they're still making those weird snoring or gargly sounds, the dose can be repeated 2 to 3 minutes later if you're having very minimal responses. It's a little more difficult to use than our other options just because it does come in the vial and has to be drawn up. Anybody that's ever had to draw up medication, it's a little awkward at first, especially potentially for your patients who aren't used to using syringes and needles. And then if you add on top of that the stress, so maybe this is their family member that they find that's overdosed, maybe it's their friend, it's a high stress situation, and so it takes a lot of dexterity to be able to pull up that medication and administer it. Again, there's a needle involved. A lot of people don't like needles. but it is the lowest in cost and it is widely available for our patients. As we look at Evzio, Evzio is our auto-injector. It comes in a dose, currently it's in a 2 milligram per 0.4 mils. It had been previously in a 0.4 per 0.4 mil concentration. They've decided to no longer manufacture that, so you'll see the higher dose. What's really interesting and unique about this product is it has an electronic voice instruction system. So as you use it, the kit tells you exactly what to do. So you can see on the box on the bottom right, there's the sign that says pull. Once you've pulled that, Evzio will walk you through exactly what needs to be done. How do you remove the cap? How do you apply it? Again, it's going to be given, it says intramuscular or subcutaneously. That part is just because you'll put the device onto the patient's thigh or their arm, but thigh works best for this one. Hold it on their outer thigh and hold it in place. And it's really just a matter of how deep that already preset needle is administered. If it ends up in the sub-Q tissue, it's not a problem. We don't worry about that. But to tell your patients to hold it really tight to the patient's outer thigh and hold it in place. So it'll count down as it's injecting the medication, and your job in that point is to just hold it there so that the medication can be administered. And it does take 5 seconds to administer all the medication. So again, if a patient puts it on their leg or on the patient's leg, and then it starts to inject the medication and they get nervous and they pull it away, that medication will probably end up somewhere between the device and the patient and not be effective. So it's important to hold it in place. Again, if we're seeing minimal or no response in our patients, we can administer a second dose. And so these Evzio do come in 2 packs. They come with 2 active dose cartridges as well as 1 tester. So that is nice with this one. You can have a tester. You can practice. If a patient is at risk of overdose, they can show it to their friends and their family members so that if they are in the case of needing a dose, everyone's aware of it. However, there have been other studies looking at the ease of administration for this, and even children are able to appropriately use this because, again, that voice talks you through it. However, it is the most expensive, and currently without insurance, it's in thousands of dollars. So may not be appropriate for some patients, but it is covered by some insurance companies. And again, here's the administration. You're going to pull it out. Once you've pulled that, it'll start talking to you. It'll ask you to pull out the red bottom piece. That's where the needle is and where it will administer from. Put it to the outside of the patient's leg. Hold it there for 5 seconds, and again, it'll count you down as it delivers the medication. Our third option is Naloxone in our nasal atomizer. So this is the injectable product that we talked about. Those of you that might work hospital practice, these might look familiar. They're often kept on the crash carts. So we're going to take this injectable product and add a nasal atomizer to it so that we can give the medication via intranasally. So it's a 2 milligram per 2 ml syringe, so a little lower concentration. It does need both pieces. So if you're in a pharmacy and you're dispensing this, and these are also covered by some insurance companies, make sure that you are administering the box of the naloxone that contains that injectable ampule inside, as well as the nasal atomizer. And depending on your wholesaler, you might have to go through a different wholesaler. Some are not available through the drug wholesalers. So make sure you're dispensing both pieces because it's that atomizer that will take the syringe and make it a fine mist. And so you're able to take the medication that's in there, that liquid, and it'll provide it as a mist that then can be inhaled into the nares and have its effects. To administer, it's 1 spray, and we do half of the full dose. So it's a milligram or 1 mil, so half of it into one nostril and then the other half into the other, and that's considered 1 full dose. Again, like the other products, you can repeat after 2-3 minutes if you had minimal or no response. I think it's easier to use than the injection because you don't have to worry about a needle. However, there are lots of pieces, as you can see even from this picture. And it's cheaper than our current intranasal product as we're looking at comparing all of them. So here's how you would educate your patient on how to use this. So if you take that, the end of the carpet, you take off the colored caps. Then you take the vial of naloxone that comes in that box. You take off its colored cap. You screw them together. You screw on the nasal atomizer on the end, and then you inject it into the nostril. Again, half of it into one nostril, the other half into the other nostril, and you can repeat it if needed. Our last product is the intranasal device that comes pre-filled under the branded name of Narcan. So this is a 4 milligram dose in only 0.1 mil, so it's very concentrated. It also comes in a 2-pack, so similar to the Evzio. And it can be delivered as one spray into one nostril is the full dose, so you don't have to worry about dividing it between two. Again, like all of these, you can repeat it if needed. I personally think that it's the easiest to use. Like you said, it's ready to go. It's pre-filled. There's nothing to attach. There's not even a cap you need to pull off. You just need to pull it out of the package. It is a little more expensive than the generic pre-filled syringe with the atomizer that we just talked about, but again, you don't need 2 pieces. And there are some discounted pricing that's available to community partners, so anybody that's buying it with a grant or community programs like fire departments, police departments, EMS, there's a potential to get this at a reduced price through the drug manufacturer. Here's how you can administer the medication of Narcan. So you'll hold it, you just pull it out of the package, you hold it like this, you put that top nozzle into the patient's nostril, and you press the bottom button, and that's a dose administered. When we compare all of these, you can see we've talked about all of them. They vary a little bit in their strengths as well as in their concentrations, and how many total doses of naloxone you get in a kit. So with your nasal atomizer or your IM injection, both of those as pharmacists, or prescribers, you're going to have to decide how many of those you want in a kit. However, Evzio and Narcan come both as 2-packs, so you'll receive 2 doses of each of those. When you prescribe one kit, is actually 2 doses. Again, you can see the doses are listed here. The costs, with Evzio being the most expensive, the vials for intramuscular injection being the least expensive. And again, each of them have a little bit of unique considerations as you're going through and thinking about how to administer these.
We're going to move on to addressing naloxone myths next. Before we do this, just a few points of summary. So, of course, the person that's experiencing the naloxone overdose is not going to be the one that's going to be administering naloxone. So if somebody's undergoing an overdose, they're not going to be coherent enough to administer. So it's really important that you're talking to the family and friends. You can, of course, also counsel the person who's at risk of overdose, but it's really important for their family and loved ones and people that are around them to know where that kit is. So we do recommend that when that person gets the kit, that they let everybody know where in the house the kit is going to be, or the workplace, wherever it is, and have it well marked. And then really just that awareness of where it's going to be. We also know recently that the Surgeon General has recommended that everybody carry naloxone, especially people who are at risk of overdose and the loved ones of people who are at risk of overdose. So I think that's another key point too, that hopefully it's going to be more and more naloxone out in the community. So we're really hoping for more prescribing and also more dispensing of naloxone. So we're going to move now into the myths when it comes to naloxone. We've heard a lot of these myths from healthcare providers in our area throughout Minnesota and, of course, throughout the nation, too. So we're going to go through these myths that have come up and talk about them with you. So the first myth is that the availability of naloxone encourages risky opioid use behavior.
And really, when we address this myth, there is no data that exists to support the concern that naloxone does encourage risky opioid use behavior. We know that addiction is a disease that causes continued risky opioid use behavior despite the consequences. So irregardless if a patient receives naloxone, addiction in itself, the disease that it is, has that continued wanting to continue that risky behavior. We also know that addiction is not cured by naloxone. And so even though we're addressing the acute overdose, naloxone isn't doing anything to really stop that use from happening again. And so as we think about that, we save their life, but we provide an opportunity to consider addiction treatment. So our naloxone is kind of our Band-Aid at the time, but really needs further treatment to get down at the heart of why they're using opioids. We do have several studies looking at opioid use and then the naloxone use along with it. And so a study of 2010 done by Wagner looked at injectable drug users. And this was actually done on Skid Row. And looking at 53% of those patients reported decreased drug use 3 months after participating in opioid education and naloxone distribution. So they did this education, they gave these patients naloxone, then they measured them 3 months later, and 53% of them said they were actually using less opioids. And a study done by Wally in Massachusetts showed that educating the opioid users and their family and friends, so again, using that support system that the patients may have, had a significant reduction for 27 to 46% adjusted rate ratio of opioid overdose. So again, another successful study of using that education. Doe-Simpkins in 2014, so a little newer study, showed there was really no change in heroin use after 30 days of take-home naloxone. So 38% said they had decreased use, 35% said they had increased use, and 27% they had really no change in use. So there was no significance between these reports, and I think what this shows is that the good part of it is that even though there were some that had increased use of heroin, there was significant, or they weren't significant, but there were a group that showed that they had decreased use. So there really was no effect, but the chances that we did potentially save a life with this naloxone is the important part. In a study done by Bird, suggested that opioid overdose-related deaths decreased by at least 50 or 25% by, again, using that education through opioid education, naloxone distribution. And this is actually a really interesting study because it looked at those patients that were being released from prison or on hospital discharge, so patients that had longer stays in the hospital where their opioids were either not given at all in the case of prison, or maybe were given less than they had previously been using while they were in the hospital. And so they were giving naloxone and education at time of discharge, and they saw, again, 25% reduction in overdose deaths just because they had the naloxone and then they had that education. A study done by McDonald was a review that showed that take-home naloxone programs decreased the overdose mortality within the community, so another great thing. And then a study done by Jones in 2007 found no evidence of increased heroin use after the patients received naloxone.
I think one other point when it comes to the concern that if you dispense naloxone or give somebody naloxone that you're encouraging use is just to think about the fact that when somebody's overdose is reversed, they're actually going into immediate withdrawal. Mm-hmm. And I've heard somebody that's experienced this before and said, I would never choose that. So think about that too. When we give somebody naloxone, we're giving them a chance to save their life. We're not promoting the use, we're just giving them that tool. Recognizing that it's not a pleasant state to have to use naloxone afterwards, that withdrawal is not pleasant. It's just a life-saving technique.
And then myth 2, it's difficult to offer naloxone to our patients without offending them.
And I think that this is really, if we can think about substance use disorder as a disease state, I think that we can actually get through this myth pretty easily. Just thinking about how you talk to anybody else who had any other chronic disease state. If somebody had asthma, you wouldn't feel like you were offending them by giving them an inhaler and instructing them on how to use that albuterol emergency inhaler. It should be the same thing with naloxone. So offering naloxone in a non-judgmental manner, just as you would with any other disease state, and really offering it to anybody who might benefit from its availability. So we've already kind of highlighted some of those high-risk populations and high-risk people. So the folks that have over 50 morphine milliequivalents per day, or definitely higher than that, and really conveying that safety perspective. So Anyone that has those higher doses, anybody that has a history of taking a benzodiazepine, we talked about that as being really increasing somebody's risk of an overdose. Folks that also have those high-risk disease states where we looked at previous history of substance use disorder, but also breathing issues and other sorts of health conditions. So we actually want you to think about it as like epinephrine for an anaphylactic reaction or glucagon for hypoglycemia. It's the same thing. Really thinking about this as a medical condition rather than any kind of moral failure. And I bring this up because we know that that is a major barrier for pharmacists and prescribers alike. We really need to think about this as a medical condition if we're going to make any headway, and we really need to think of naloxone just like we would epinephrine. So the goal, of course, is that it's never needed, but that it is available. And so when we talk to our patients about that, we will just explain it's kind of like a seatbelt, for example. Mm-hmm. We hope that you never need it, but if you do, that it's there, just like we would in those other examples. It's also, if somebody does maybe express a desire for treatment, it's really important to really think about the language we use when we help provide education. So again, providing that non-judgmental stance. So thank you for sharing your concern. I do have some resources to help you in really kind of practicing that conversation. What's that conversation going to look like in a very just casual, non-judgmental, matter-of-fact way? Using that assessment step, do you have a primary care doctor, nurse, counselor, case manager, or care coordinator who can talk to you more about this? So really trying to delve more into what are the resources that they have available. Maybe it's a family member that really helps them with their health care. Maybe they do have a primary care provider, but we have found that a lot of folks don't. So really trying to find out how to plug them into the resources that are available to them. Then the next step is the referral step. So ensuring that they do have that point person to call and to schedule an appointment. If there is no clinic in the area, offering to look up the clinic nearest to their home, or using the referral list provided. There's referral lists online if you Google in your area. There's a way to do that. We also have the Opioid Dashboard, which has a host of resources for people that are in Minnesota. So if you were to Google Minnesota Opioid Dashboard, you can navigate through that site to find resources as well. And then asking permission. So would it be okay if we looked at a list of resources together to see what would be the best fit? There are some really great resources. Again, these are on the dashboard, and there's some instructions here, but Fast Tracker is really great. There's a Fast Tracker for mental health and for substance use treatment facilities with openings. So this is a really great way if that person is ready at that moment to seek treatment, or they really want to know where they can go, or maybe it's a family member that's wondering, how do I get my loved one into treatment? Those are some really great resources because we know that sometimes it's a narrow window when people are ready for treatment, and so we do want to get them plugged in as soon as we can. Also, there's the SAMHSA National Helpline, which would be really key to have this 1-800 number at your pharmacy or at your desk if you're a provider, just kind of at your fingertips. These are resources that are available 24/7, so really calling this number can be used to connect to local treatment facilities as well. The next myth we're going to get into is that the risk of potential harm to the patient and others during an acute opioid withdrawal are too high to use naloxone.
So we talked about this previously. The risks of withdrawal are not high enough. So that really is a false, it's a myth, in the sense that opioid withdrawal is not life-threatening, as we mentioned previously, but it's very uncomfortable. We also know that our patients, if they had severe poisoning, so if they had overdoses where they really had a lot of those mu receptors that were overtaken, and we're now having that naloxone and we're ripping off a lot more of our opioids, if that's kind of the easiest way to think about it, that those patients see more of those adverse effects. So those patients were at greatest risk of death because they had such this overabundance of opioids. Those are the patients then that tend to have higher withdrawal effects. The other thing, you might hear reports of a person being really combative after receiving naloxone, and that can happen. A lot of that is depending on what's being used, as well as how the patient was at baseline. It's a scary situation. They come out, they're feeling awful, So that might be agitation alone. They're in a lot of pain. They have that nausea, vomiting, diarrhea, and it's pretty immediate. So that they might be agitated with that. The other thing that we can see is not all patients use opioids alone. And so potentially they had a polysubstance overdose, things like speedball, where you're using a stimulant with an opioid. And so we'll reverse the opioid, and now all you're seeing is the stimulant. And so it's not necessarily that the naloxone caused this, but we might see effects of the other drugs without, we've taken away that depressant effect of the opioid. So it is possible that our patients may become agitated or combative after receiving naloxone. Again, it's really important that we're giving them that chance to live through their overdose. But it is an important point when you're telling our patients or their family members or whoever you're counseling to give them naloxone that they administer to the patient, but they also stay safe for themselves. So if they aren't comfortable, to administer the dose and then remain a safe distance from the patient if that's what they feel comfortable with.
I think, and one more thing before we get into legal considerations, I do want to add that people do get better. People do recover from substance use disorder, and sometimes they're ready after maybe no opioid overdose reversal with naloxone. Maybe one overdose with naloxone really gets people thinking and they're ready to enter recovery, but sometimes it takes many times. I've worked with people in recovery, and I know people that have overdosed and had their life saved by naloxone multiple times before they were ready to enter into treatment. So each person's different, but again, we want to stress, even though this isn't the solution to the opioid crisis, this is a very valuable tool for saving somebody's life. And this life is important. Like we mentioned earlier, this is your community member. This is somebody's family member, somebody's son or daughter. So keep that in mind too as you're dispensing naloxone and prescribing it as well. So next we're going to get into the legal considerations when it comes to naloxone. We do want to stress that legal protection does exist for healthcare providers prescribing and dispensing naloxone. This is one concern that we've heard from our prescribers and from our naloxone, our pharmacists throughout the state, that people do have concerns about liability. Statutes do vary state to state. So, for example, in Minnesota, Wisconsin, and North Dakota, there's criminal and civil liability immunity to prescribers and pharmacists who prescribe, distribute, dispense, and administer naloxone lawfully. So you can kind of look those up depending on what state you're at. This is also an area, when it comes to naloxone and legislation, there's a lot of pending naloxone, a lot of movement in our laws regarding naloxone to get it more available to people. So the naloxone rules at the time of this particular recording, so right now in Minnesota, for example, we have the ability to enter into protocols, pharmacists and providers, so that somebody can come into the pharmacy and get naloxone without that written prescription. But more and more states are moving towards legislation that supports people just going in and getting that naloxone without that protocol being necessary. So statutes do vary state to state, and they are changing, so we encourage you to look those up. Minnesota statutes specifically, emergency medical responders, police officers, and staff of designated community programs may be authorized to administer opiate antagonists. Authorized by prescribers or standing order or protocol, the individuals must be trained to recognize signs of opioid overdose and use of opioid antagonists. So we are seeing some of these programs setting up these protocols so that everybody is fully covered from a liability standpoint. We do have other statutes, though, such as Steve's Law, which actually provides, it's called the Good Samaritan Law in Minnesota, where non-health professionals acting in good faith may also administer an opiate antagonist and be immune from civil prosecution as well as not be liable for civil damages. And this is important, especially now, as we mentioned earlier, with public health professionals urging that everybody carry naloxone. It's important for people to know that they are covered if they are to administer it. This also applies to licensed healthcare professionals who prescribe, dispense, distribute, or administer an opiate antagonist directly or by standing order. And of course, opiate antagonist, that's the same thing as naloxone. It's just a different way of referring to it. Currently in Minnesota, there's different methods to access naloxone. We have a valid prescription direct to patient from the prescriber. There's a lot of room to be improved with this. We really, we'll discuss this at the end, different ways that we can work together to improve, to turn the tide on the opioid crisis and reduce opioid overdose. But there's ways that healthcare systems can work together to increase those prescription rates from the prescriber. So individuals who do have those high doses of opioids are automatically prescribed naloxone, and when they go to the pharmacy, they'll have that prescription ready for them. There's also organizations that provide naloxone. We have great partners in the state of Minnesota with the Rural AIDS Action Network, also known as RAN, the Steve Rumbler Hope Network, and Adapt Pharmaceuticals, as well as others such as Valhalla, who help us to increase the amount of naloxone that's out in the community so that it's in the hands of people that need it. We also have pharmacists who are able to join in protocol agreements from authorized prescribers where any Minnesota licensed prescriber, such as a physician, advanced practice nurse, or physician's assistant, can join with the pharmacy. Several large and small chain pharmacies in Minnesota have protocols in place, and we're working on expanding those even further. And of course, any of the above may prescribe to a third party.
And so Laura mentioned the Minnesota Opioid Antagonist Protocol. So this is any Minnesota licensed prescriber, again, physician, advanced practice nurse, physician assistant. We can enter into a protocol with one of these licensed prescribers. The Minnesota Board of Pharmacy has a protocol that's already, it's a protocol. It really, if you agree with all the steps within that template, you can have that licensed prescriber sign it, and it's official at that point. Or if you want to make a more personalized, individualized template, something that's specific to your pharmacy, your clinic, your community, whatever the needs are within your own community, we definitely encourage you to do that. And then again, you can, if you have the connections with the licensed prescriber, again, maybe it's someone at your own clinic, maybe it's a community physician, go ahead and ask them. Otherwise, there's also community health board medical consultants that will sign these protocols, the county public health medical consultant, so in our case, Dr. Beth Bilden, who helped with this continuing education program, will sign. And also Dr. Ruth Linfield, the Minnesota Department of Health Medical Director, has also said she will sign any of these protocols. So if you don't have a physician that will sign it, and we really do encourage that, I think that creates a lot of relationships between pharmacies and providers. It opens that discussion of everything from prescribing practices to how many doses of naloxone are you dispensing off this protocol. I think that's really good. But again, if you're working in a place where you don't have that connection with physicians or a nurse practitioner, advanced practice nurse, physician assistant, then Dr. Ruth Linfield at the Minnesota Department of Health will sign that for you, and so you can get the naloxone out into your community. Again, if you go to the Board of Pharmacy website, look under opioids, there is that state protocol that you can just print and sign, or you can tweak it as necessarily. It was written in response to the statutes that we're presenting, so really giving pharmacists the ability to prescribe through the protocol. There are some content areas that are needed, so if you are looking at making your own, we do recommend that you do pull the one that's on the Board of Pharmacy because there are some specific pieces that are needed. So some certain requirements for implementation. You also have to show that your pharmacists were trained on naloxone, and so that they've done some of this training and that they know what to tell the patients. And so there are some specifics of what needs to be in your protocol. Again, if you're looking at the Minnesota Department of Health to sign that protocol for you, there's a request piece right on the Board of Pharmacy website that you can send it to request that signature. So they made it very easy to get a signature from Dr. Ruth Linfield at Minnesota Department of Health. If that's the route you choose, it's right on the Board of Pharmacy website. It's a link that will take you there and request that signature. So let's look a little bit at the prescribing and dispensing of naloxone. So educating the patient, we talked a little bit about that. We talked about knowing the signs of opioid toxicity. And so you can find a lot. We'll have available a resource or a toolkit for pharmacists that they're able to use. And we'll also have, you can share with them even the slides from this presentation of the signs of opioid toxicity. So remember, those are things like blue lips, nails, they're not breathing, they're making funny breathing sounds. Those are the things that we want to potentially provide rescue breaths for. If a patient's not comfortable with that, especially calling 911, and then administering naloxone. So making sure that our patients kind of know the sequence of events. And again, that all patients that receive naloxone do need to be transported to a medical facility. So even though they may have been seemingly recovered from their overdose, they're not breathing again, it's still really important that they're further evaluated.
We'd like to also talk about, in closing, as we're finishing up this continuing medical education, the importance of language. So we do presentations on this topic a lot, and people want to know, we've given you some tools that you can use, hopefully some education pieces. We'll have more to share in the next couple minutes, but one thing we can all work on is the language that we use when we talk about substance use disorders. We do know that stigma is a major barrier to people seeking help for substance use disorder, and even for family members that have a loved one, perhaps a child, that's struggling with a substance use disorder. And that's something we really need to work on as healthcare professionals. Of the 23 million Americans who meet criteria for a substance use disorder each year, only 11%, according to statistics, actually access treatment, which is really, I think, crazy when you think about other healthcare conditions. Imagine if we only treated 11% of people that had diabetes or 11% of people that had asthma. So we do know that there's a lot that we can do to get people plugged into treatment, again, if we're going to really make an impact on the opioid crisis. Thinking about the words that we use when we talk about substance use disorders is really important. Words that moralize and criminalize contribute to the stigma that's currently existing in the community and serving as a barrier. For example, and I work in a drug court team, so we're always catching ourselves, but using words such as dirty when we talk about a urine drug screen versus positive, if there's something in the urine drug screen. Using words such as drug seeker and junkie versus a person with substance use disorder. Those are terms. I've worked in a community pharmacy for a number of years, and those are words that I hear. Those are not helpful, and we just never know who's going to overhear those words, who we're actually working with that maybe even have a loved one that is struggling with a substance use disorder. So eliminating words like that from our vocabulary is a good first step for all of us, and really thinking about the words we use and how do we talk about addiction. And are the words that we're choosing really treating addiction as a medical condition instead of a moral failure? So in summary, a few points for you. We do know stigma kills. That was the last slide we just presented. There's a lot that we can do as healthcare professionals within our own language, but then also recognizing we all work with others. There's a whole group in a pharmacy, so we're working with technicians and interns and really educating them on what sort of words they can be using, or finding ways to talk to people in the pharmacy about the words they're using if we're overhearing those conversations. And of course in healthcare professions too, in the ER, Heather can speak to that. We know that multiple factors contributed to this epidemic, and we need to work together to end it. And we really feel it's not just one group's responsibility. It's such a complex issue. It's going to require complex solutions, multifaceted, multi-pronged. It's not just a healthcare professional issue. It's not just a public health issue, and it's not just a law enforcement issue. That it really requires all of us working together. As we discussed, there's several different formulations of naloxone that are available, and there's different pros and cons to each of those formulations. So hopefully you've gained an appreciation for how they're different and what the advantages to each of them are. There are several ways that patients and third parties can access naloxone, which we've gone through. Of course, Minnesota statutes offer legal protection for prescribers and dispensers of naloxone, and each state has different laws. So we really encourage you, if you're not in Minnesota, to take a look at what the laws are in your state. And of course, that naloxone saves lives. We also want to let you know that we have a Google Drive folder with additional resources. Of course, we only have a limited time here with you today, but if you take the time to visit the Google folder, you'll see how different resources we've set up for links to training modules, educational resources for patients and for providers, the Minnesota Department of Health opioid dashboard link, the CDC MME app link, and a counseling checklist that we think you'll find helpful as you're working on these conversations with your patients. We also have a list of references. We will scroll through these in case you wanted to take a look. Hopefully you have this also available to you in a Microsoft Word version or a PDF so you can look these up on your own. But there's a lot of research that's coming out on the treatment of opioid use disorders, more and more in the most recent years. So we do encourage you to take a look at what the current data says. This is my contact information. If you want access to the Google Drive, feel free to email me or Heather. And we also had, although we're really at the end of our time here, we did want to save some time just to talk about, as you're looking at what your role is in the opioid crisis and how you as a healthcare professional or as a pharmacist can take on a greater role and really fulfill what potential you have. So we really want you to think about naloxone policies and procedures. This is an area of a lot of study. And Heather, do you maybe want to talk briefly about your naloxone procedures in the ER?
Yeah, so this is something we added to our emergency department at St. Luke's. So the medical director of our emergency department contacted me and wanted to realize that opioid addiction and use was really prevalent, and we were seeing a lot of those patients who maybe received naloxone in the field by EMS or with us in the emergency department, or maybe didn't receive that but were at risk. So we started a naloxone distribution program out of our emergency department, and so either myself as a pharmacist, the nurses, or the physicians do some baseline education about naloxone, again showing them what are signs of an overdose, and it's their patient, their family member that's present with them and during their visit. And then we do give them, we use the intranasal, the Narcan, the branded product, which we were able to receive through one of the discounted programs with ADAPT. And so those patients do take a Narcan kit home with them. And hopefully just by, again, getting that naloxone into the community, we're potentially reducing the number of overdose deaths that we'll see through St. Luke's.
Mm-hmm. Different healthcare systems in primary care, for example, are also working on naloxone policies and procedures where everybody who has a certain MME of opioid is flagged and then automatically gets a naloxone prescription. So when somebody picks up their prescription for OxyContin, for example, it also comes with naloxone. So there's different things that healthcare systems can do there. And of course, working with our different pharmacies throughout the state to set up protocols. We've had great luck with some of our smaller counties that have they're completely on board, so every pharmacy in that state now has a protocol in place. So we're moving on to bigger counties now. And again, legislation might change, so those protocols might not even be needed, but in the meantime, that's what we have available to us, so we're working on that.
I was going to jump in with prescribing, too, so as Laura mentioned, trying to change your practice so that those of you that are prescribers that are watching this, or even pharmacists as you're filling those opioids, thinking about that and asking, should they have some naloxone to go along with this? We talked to one program who's using a "Do you want fries with that" kind of campaign of thinking about how they do kind of go together. And so, there really isn't a better reversal agent for any other substance, excuse me, that's as safe as naloxone. And so really thinking about how we're prescribing. Are opioids, are they appropriate at all? Using some of the new prescribing guidelines that are coming out. And then thinking if you are prescribing opioids that you should also be prescribing naloxone.
Mm-hmm. I think along with prescribing too, we have identified there's healthcare systems that are working on opioid tapers. Mm-hmm. So perhaps there's a patient that's been on very high dose opioids for a long time. There's specifically trained staff that are working on slowly tapering those people off their really high dose opioids. And we've seen good luck in pharmacist partnerships with healthcare systems in getting those tapers, really safe tapers that aren't going to just cause somebody to go into withdrawal and then maybe seek their opioids on the street. So that's another area of further study and collaboration.
And I think as we think about patients that are tapering off, or especially we think about prescribing, it's not, I don't know about your medicine cabinet, but it's pretty common to have leftover opioid prescription medications, that are just left over. Maybe you had a surgery or some other injury that you had a short-term use and you didn't use your whole prescription, really helping those patients that are in that same situation get rid of their opioids. So whether you are an authorized collector through the Board of Pharmacy and you're able to take back that medication, we know that that's a big program. It takes, it's not as easy as just accepting that. There's how you do that and how you dispose of it. Or you're just connecting your patients with another resource within your community, a drug take-back event. Maybe it's the sheriff's department. But giving those patients the opportunity to know where that is, and so our patients aren't sitting with a lot of opioids that aren't being used that could get into the wrong hands, whether that be a child or someone who's looking to overdose or use that.
Mm-hmm. Along the same lines, we really encourage healthcare providers and pharmacists to really become engaged in public education, partnering with public health, just really becoming aware of what the data says for syringe access, for example. We know that pharmacists in Minnesota are not widely supportive of syringe access, and a lot of that is probably because of the same sort of myth that if you give somebody clean syringes that you're promoting use. And we know with harm reduction that people will recover when they're ready to recover. But in the meantime, there are harm reduction strategies that help to reduce the impact from the opioid crisis and, of course, the comorbidities such as hepatitis C. So we really do encourage really participation of our pharmacists and our healthcare providers in local task forces and statewide task forces. Our input is desperately needed. A lot of times healthcare providers are not well represented on some of these coalitions, and we really need to be a part of finding solutions. So we do thank you very much for your time today. If you have any questions, please let us know. And thank you for this opportunity.
Thank you.